My name is Jara and I will be talking about long-acting Cabotegravir and Rilpivirine for maintenance of HIV suppression. First we have the definition. What is HIV and HIV suppression? HIV stands for Human Immunodeficiency Virus. It's a virus that attacks cells that help the body fight infection, making a person more vulnerable to other infections and diseases. It is spread by contact with certain bodily fluids of a person with HIV. Most commonly during unprotected sex without a condom or HIV medicine to prevent or treat HIV, or through sharing injection drug equipment.
Hey guys, welcome to my channel. If you find this video helpful, please like, comment and share. And don't forget to subscribe. Thank you. Today we are going to discuss about antiretroviral drugs. As you already know, right now there are 5 types of antiretroviral drugs available in the market. Let's start with the fusion inhibitors. Here you can see a man is trying to inhibit the fusion between the rock and the tide on the seashore. So he is the fusion inhibitor. First drug Maravirok, which sounds like a rock, and second drug Enfuvitide, which sounds like tide. So just remember this picture. Second group is protease inhibitors. Here you can see there is a navir at the end of the name, which is common for all of them. You can remember it with this mnemonic: never tease a pro. Never signifies navir and pro and tease signifies protease. Next group is integrase inhibitors. Here you just have to remember these 4 letters EEGR, which is common for all the drugs present in this group. Now come to non-nucleoside or nucleotide reverse transcriptase inhibitors. Here this portion VIR is common for all of them, but this portion must have to present at the middle of the name, not at the end. And fusion inhibitors are the exceptions. Now rest of the drugs are included in nucleoside reverse transcriptase inhibitors or nucleoside reverse transcriptase inhibitors. You don't have to remember them separately. That's all guys. Please don't forget to subscribe. Have a nice day.
Now, what is Cabotegravir? Cabotegravir is an investigational integrase strand transfer inhibitor currently under study for HIV treatment and for HIV prevention, pre-exposure prophylaxis. Cabotegravir is a structural analog of dolutegravir, and like dolutegravir, it is dosed once daily, has potent anti-HIV activity, and appears to have few bothersome adverse effects. Cabotegravir, however, does not have as high a barrier to resistance as dolutegravir. Cabotegravir is being studied in both an oral form, half-life of 40 hours, and a long-acting, injectable nanosuspension, half-life of 21 to 50 days. Now we have Rilpivirine. Rilpivirine is a prescription for the treatment of HIV infections in adults and in children 12 years of age and older who weigh at least 77 pounds, who have never taken HIV medicines before. Rilpivirine is always used in combination with other HIV medicines, and HIV medicines can cure HIV or AIDS, but taking HIV medicines every day helps people with HIV live longer, healthier lives. Now we have the applications in medicine. The Cabotegravir and Rilpivirine long-acting regimen is investigational and is not approved anywhere in the world. More than 1,100 patients from 16 countries demonstrated that when injected monthly, it was as effective as a standard of care, daily, oral, 3-drug regimen in maintaining viral suppression throughout the 48-week study period. It's also a replacement for oral therapy, and it causes improved immunologic function and extended survival.
After entering the cytoplasm of a CD4 cell, the uncoating of the viral core can occur. The matrix core disintegrates, releasing the capsid with the HIV genetic material and associated enzymes into the host cell. The capsid then sheds its coat. The two viral RNA strands, which are themselves coded, and the viral enzymes are then released into the host cell cytoplasm. The reverse transcriptase, or RT enzyme, is then activated, and it is now ready to convert viral RNA into single-stranded DNA. At this stage, the non-nucleoside reverse transcriptase inhibitors, or NNRTIs, are able to block the function of the viral RT enzyme. NNRTI drugs target the viral RT enzyme. A NNRTI molecule can bind to the active enzymatic pocket or active catalytic site of the reverse transcriptase enzyme. The binding of an NNRTI molecule to RT prevents the enzyme from being able to convert viral RNA into DNA. Hence, the process of reverse transcription is inhibited and the HIV infection cycle is brought to a standstill.
Now we have the pros and cons. In the pros, we have a better tolerability, higher patient satisfaction, and reduced need for daily adherence. We also have it as an alternative to oral treatment. Participants report greater satisfaction as they don't need to use pills and no serious adverse events.
So my trial is called Atlas, and it's a phase 3 study of a different way of taking anti-HIV medicines by injection as opposed to daily oral therapy. And so there are two drugs involved in the study. One's an integrase inhibitor called Cabotegravir. One's a non-nucleoside reverse transcriptase inhibitor called Rilpivirine. They're both formulated to make long-acting injections possible, up to a month apart, perhaps in the future even less frequently, but in this study they were given to patients a month apart. So the study enrolled patients on conventional oral therapy that had virologic suppression. They were randomized to continue their daily oral therapy or to go on to monthly injections of Cabotegravir and Rilpivirine, and then at 48 weeks we looked at the results, and they were very similar in terms of the number of patients in each arm that had detectable virus, very small numbers in each arm, more than 90% suppressed in both arms. It was a non-inferiority design, so non-inferiority was met, and there were 3 virologic failures in the investigational arm with the injections.
Now we have the cons. Injection site reactions are common. Side effects include fatigue, fever, headache, and nausea. Weight gain has now been reported as a potential complication, and large knowledge gaps of its efficacy and safety in other ethnic backgrounds. Now you have the cases in Ecuador. HIV in Ecuador. Ecuador estimates are close to 35,000 people living with HIV, with prevalence of 3 cases per 1,000 population, being 31.4% women. About 68.5% of them receive treatment. HIV infection is a public health concern in Ecuador, affecting mostly young males. More than half patients are on antiretroviral therapy, and most patients are not in AIDS stage. Now about the drugs used. Both Cabotegravir and Rilpivirine are drugs that haven't been approved by the FDA, and results may differ according to the country. Ecuadorians haven't participated in any studies, so the efficacy hasn't been confirmed in patients in Ecuador. The drugs used in Ecuador are tenofovir, emtricitabine, efavirenz, sidovudine, lamivudine, and efavirenz in conjunction. Now we have the conclusion. Monthly injections of long-acting Cabotegravir and Rilpivirine were non-inferior to standard oral therapy for maintaining HIV suppression. Injection-related adverse events were common but only infrequently led to medication withdrawal. The FDA hasn't approved it as an alternative to other NNRTIs because further investigation is required. If approved, it could even help as prophylaxis.
Question about long-acting therapy, it's a really important one. We have terrific therapies, but they all require that people take pills every day. So there's been a strong interest in developing long-acting therapy. So we've seen what's called phase 2 data. So we've seen data on injectable therapy that can be given either monthly or every other month to people who have HIV who have already been suppressed on their current therapy. And that study has now been out to over 2 years, 96 weeks, showing actually that both injectable arms were about as good, maybe even a little bit better than continued oral therapy. But the proof, of course, is in the larger phase 3 studies. 2 large phase 3 studies are ongoing. They're fully enrolled and should reach their primary endpoint in the next year or so. So realistically, when will it be in the hands of clinicians? I would say it's probably about 2 years from now. The therapy, it's injectable. It's an intramuscular injection, so it's an injection that has to be given by a healthcare provider at this point. I think the longer-term goal, which we're talking, 5 years or more, are therapies that can be given even less often, maybe every 3 months or even maybe every 6 months, and perhaps could be given in not necessarily in a healthcare setting, or might be implantable like some contraceptives. So that's the kind of longer-term future. The short-term future, I think, is about 2 years for an injectable therapy, provided, of course, that the phase 3 studies, meet their mark. Yeah, we think it'll improve treatment adherence. There's several ways to look at it. It might be particularly good for people that have problems with pills, so they're engaged in care, but they just can't take pills very well. But also, I think it's an opportunity to reach people that can't stay engaged in care, and we might need, kind of novel ways to reach them. Looking at other ways to administer the drug. Could it be done in pharmacies? Could it be done in different healthcare settings, not necessarily in an HIV specialized healthcare setting? Could we even do it in a mobile way to reach out to people using vans or other ways to kind of go out to people to give the therapy? But yeah, adherence is a big goal. But a lot of people just don't want to take pills. Even people who are really adherent. What you'll hear sometimes is, every day I take a pill, every day I'm reminded that I have to have HIV and I have to take this pill. So there's some people that are very adherent that would prefer to be on an injection, especially if it was every 2 or every 3 months.